Good evening, everyone. So today we will start with the chapter of transplantation, chapter 82 of Bailey. If you look in the historical perspective, I'll be discussing the important points only. So let's start with that. If you look in the historical perspective, the modern era of the transplant began in the 1950s, and it relied on the surgical techniques for anastomosing blood vessels that has been developed at the start of the 20th century by Matthew Jabole and Alexis Carrel. Carrel and Jabole, the modern era of transplantation. Then the first successful kidney transplant was a living donor transplant performed between identical twins in 1954 by Dr. Joseph Murray. Nothing much is important in the remaining part. This table is very important as few of the potential questions are there. In 1954, Dr. Joseph Murray, who conducted the first successful kidney transplantation between the identical twins. Then Stars, who performed the first liver transplant. Then Lillehi and William Kelly. Lillehi and William Kelly performed the first whole organ pancreas transplantation. It was along with the kidney transplantation. Then Dr. Bernard, very important, who conducted the first human heart transplantation. Fritz Derome performed the first human lung transplantation. Dr. Pitchell-Mayer, who performed the first splitting of donor liver for use of the same liver in two recipients. Pitchell-Mayer, splitting of donor liver. Nothing much in the remaining table. Now let's look at the summary box here. The allograft is an organ of tissue transplanted from one individual to another. From one individual to another from same species. Then alloantigen are the transplant antigens, and alloantibodies are transplant antibodies. These are few terms which has been used repeatedly in the subsequent part of the chapter. Then we know what is HLA. Xenograft is something which is performed between different species. Then there is orthotropic graft and heterotrophic graft. This is very important. An orthotropic graft is a graft placed in its normal anatomical site, while heterotrophic graft is a graft placed in a site different from that where the organ is normally located. Like for kidney, we place the graft in the right iliac fossa, but not in the anatomical position, that is the lumbar region. Graft rejection. Graft rejection, nothing much is important. Important part is the last paragraph. The allografts trigger a graft rejection response because of allelic differences at polymorphic genes that give rise to histocompatibility antigens, the transplant antigens. And these are two transplant, basically histocompatible antigens are two, of which ABO blood group antigens and HLA are the most important. Two are the most important, HLA and the ABO. If we look into the ABO group antigens, and ABO group antigens are not only expressed by the red blood cell, but also by the most of the other cell types, not only by the RBCs, by most of the other cell types. Group O is the universal donor. Group AB are the universal recipients. And most importantly, there is no need to take account of rhesus antigen compatibility in organ transplantation. No need to take account of the rhesus antigen compatibilities. Let's look at the further part. HLA, a very important topic. The HLA are the allograft rejection in blood group compatible grafts is directed predominantly against the HLA. and HLA are a group of highly polymorphic cell surface molecules. The HLAs are strong transplant antigens by virtue of their special physiological role as antigen recognition units for display of antigens from foreign pathogens for recognition by T lymphocytes. These are strong transplant antigens because of their special physiological role as antigen recognition units for display of antigens from foreign pathogens for recognition by T lymphocytes. This table 82.2. The HLAs are the most common cause of graft rejection. Their physiological function is to act as antigen recognition units. They are highly polymorphic, and amino acid sequence differs widely between individuals. That is why they are highly polymorphic. Then HLA-A, B, C, which belongs to class 1, HLA-DR, DP, and DQ, which belongs to class 2. They are the most important in organ transplantation. Very important table. Then let's proceed. So there are two types of HLA molecules, HLA type 1, HLA class 2, and they are broadly similar in structure but have different cell expression patterns. HLA class 1 antigens are present on all nucleated cells, whereas the HLA class 2 have a more restricted distribution and are expressed most commonly on antigen presenting cells. HLA class 1 on all the nucleated cells, and HLA class 2, they are actually having restricted distribution and only on antigen presenting cells. And what are those antigen presenting cells? Dendritic cells, macrophages, and B lymphocytes. The T cells recognize the HLA molecules via their T cell receptors, the TCR, T cell receptors, but full T cell activation also requires the delivery of an additional or second signal by the interaction of co-stimulatory molecule. So the T cell activation by HLA molecules requires an co-stimulatory action between the antigen presenting cell and the T cell. This table 82.2 is very important table here. It tells about the class 1 and class 2 HLA molecules. The class 1 includes the HLA A, B, and C. The class 2 includes HLA DR, DP, and DQ. The structures, moreover, the structures of class 1 HLAs contain heavy chain and beta 2 microglobulins, while the class 2 have alpha and beta chains. We know that the distribution of class 1 has all the nucleated cells, while the class 2 cells are presenting on antigen presenting cells. Effector mechanism of rejection. Very important. What is the effector mechanism of rejection? So HLA expression by graft cells activate the T cells. The HLA expression by the graft cells, they activate the T cells and stimulate them to proliferate in response to interleukin-2 and other T cell growth factors. These activated CD4 T cells, through the release of various cytokines, they play a central role in orchestrating the various effector mechanisms responsible for graft rejection. The cellular effectors of graft rejection include CD8 T cells, which recognize the donor HLA class 1 antigen presented by the graft and cause target cell death through the release of lytic molecules. We know that CD8 T cells are cytotoxic T cells, and they cause the target cell death by release of lytic molecules such as perforins and granzymes. Very important. Then graft infiltrating T cells. These all are the cellular effectors. First was the CD8, and how the cellular effectors were released. It is because of HLA expression by activated T cells, stimulating IL-2, further causing the CD4 T cell activation and the further changes. First, CD8 T cells. Second is CD4 T cells. And CD4 T cells, they recognized donor HLA class 2 antigens. CD8 T cells were recognizing the HLA class 1 antigens. CD4 T cells, they are recognizing the HLA class 2 antigens. They mediate the target cell damage and also are able by releasing the pro-inflammatory cytokine interferon gamma to recruit and activate macrophages that act as non-specific macrophages or non-specific effector cells. CD4 T cells, activated CD4 T cells, releasing the various cellular effectors. Was CD8 T cells recognizing HLA class 1, then CD4 T cells recognizing HLA class 2, and finally, the CD4 T cells provide essential T cell help for B lymphocytes. Also the B lymphocytes, they differentiate into plasma cells and they produce the allo antibodies that bind to graft antigen and induce the target cell injury directly or through antibody dependent cytotoxicity. This diagram depicts the class 1 and the class 2 of HLA. We saw that class 1 is actually an heavy chain, and the alpha and beta subunits, and class 2 is having alpha and beta chains. Sorry, class 1 having a heavy chain and beta 2 microglobulin, and class 2 having alpha and beta chains. My bad. This is a very important diagram. This diagram is depicting the co-stimulatory action between the T cell and the antigen presenting cells. The CD154 of T cell bind to CD40 of antigen presenting cells. This is important, MCQ. Second, the CD28 of T cell binds to CD40, CD80 and 86. CD80, which has 4, binds to 40, which has 8, binds to 80, 86. That's it. Then the types of allograft rejection. If you look into the types of allograft rejection, there are 3 types of allograft rejection. First is hyperacute, second is acute, and third is chronic rejection. Hyperacute, which occurs immediately on table within hours, acute, which occurs within the first 6 months, and chronic rejection, which occurs after the 6 months. The allograft rejection, they manifest themselves as the functional failure of the transplant, and they are confirmed by histological examination. And how your histological examination samples are taken? For the renal and pancreas grafts, by needle biopsy. For hepatic grafts, by percutaneous and transjugular biopsy. The cardiac grafts are biopsied by transjugular endomyocardial biopsy, and lung graft by the transbronchial biopsy. The small intestine transplantation samples, endoscopic biopsies, endoscopic mucosal biopsies. And standardized histological grading system, which is a Banff classification, very important. Banff classification is used to define the presence and severity of allograft rejections after the organ transplantation. Then there is a table of summary box 82.3, and it is a very important summary box. Almost every point is important. Hyperacute rejection, acute rejection, and chronic rejection. If you look at the hyperacute rejection, this is an immediate graft restriction because of preformed antibodies and characterized by intravascular thrombosis and interstitial hemorrhage. Acute rejection occurs during first 6 months, T cell dependent, and it may be cell mediated, antibody mediated, or both. Usually reversible. This is usually reversible, and we will look further into it, that how it is reversible, what drugs are used. Chronic rejection, it occurs after first 6 months. This is the most common cause of graft failure. Antibodies play an important role. The non-immune factors contribute to pathogenesis. Non-immune factors also contribute to the pathogenesis. And it is characterized by myointimal proliferation in graft arteries, leading to ischemia and fibrosis. Well, each and every point is important. Now look into detail of hyperacute rejection. This is due to the presence of recipient of preformed antibodies.
antibodies. Presence in the recipient of preformed antibodies against HLA class 1 antigens and these antigen class 1 antigen are expressed by donors, the antibodies of the recipient and antigen of donor. And these arise from a previous blood transfusion. How your recipient is having the antibodies. The recipient is having antibodies because of previous blood transfusion or a failed transplant or a pregnancy. So this type of rejection actually also occurs if an ABO blood incompatible organ graft is performed inadvertently. So after the revascularization of the graft, antibodies bind immediately to the vasculature. They activate the complement system and cause the extensive intravascular thrombosis and interstitial hemorrhage and graft destruction within minutes and hours. Kidney transplants are particularly vulnerable to hyperacute graft rejection, whereas the heart and liver transplants are relatively resistant. Very important. It is not clear why the liver is resistant to hyperacute rejection. One factor may be that it is less susceptible to ischemia than the kidney by virtue of its dual blood supply. We know that liver receives blood supply 60% from the hepatic blood supply is derived from portal vein and 40% from the hepatic artery. The figure 82.4, it is a very important figure. It shows that how antigen presenting cells activated the CD4 T cells, and CD4 T cells further activated the other inflammatory cells by virtue of interleukin 2 and interferon gamma. By interleukin 2, it activates the NK cells, and these activated NK cells cause the non-specific cytotoxicity. Then interleukin, with the help of interleukin 2, the cytotoxic T cells cause specific cytotoxicity. The effector CD4 T cells, they release interferon gamma, and directly they may cause endothelial activation. And interferon gamma also, they may cause the delay type of hypersensitivity. And by the action on B cells, B cell action is with interleukin 2, interleukin 4, and interleukin 5. A very important point. And they produce the plasma cells and eventually antibody productions. These are the central role of CD4 T cells in the orchestrating the various effector mechanism, which is responsible for allograft rejection, which we already have read, but this is a good graphical presentation. Interleukin 2, interleukin gamma, interferon gamma, and interleukin 2, 4, 5. Activated T cells, cytotoxic T cells, endothelial activation, delayed hypersensitivity, and B cells and antibody productions. Now let's look at the acute rejection. Acute rejection is actually which, before moving ahead to the acute rejection, we are missing one point, that hyperacute rejections can be avoided by ensuring the ABO blood group compatibility and also performing a cross-match test on recipient serum to ensure that there is no clinically relevant antibodies directed against the HLA1 expressed by the prospective kidney donor. That the HLA which is expressed by the donor, recipient is not having antibodies for that. So we have to ensure that, and by that we can reduce the chances of hyperacute rejection. For acute rejection occurs in within first 6 months, and responsible inflammatory cells are T lymphocytes. Very important that acute rejection is characterized by the mononuclear cell infiltration of the graft. And the mononuclear cell infiltration is heterogeneous, induces cytotoxic T cells, B cells, NK cells, and activated macrophages. And these antibody-mediated damage may be present as evident by the deposition of complement C4D within the graft microvasculature. Very important. The complement C4D. All types of organ allografts, every organ is susceptible to acute rejection. Like we saw that hyperacute rejection is very susceptible to kidney transplants. but most of the liver transplants and most of the heart transplants, they are somewhat resistant to that. But this is not happening in acute rejection. All the organs, they are susceptible to acute rejection and typically occurring in 20 to 30% of grafts. Most common type is chronic rejection, and second most common type is acute rejection. And third most common type is, which is the least common also, is hyperacute rejection. And most episodes of acute cellular rejection can be reversed by additional immunosuppressive therapy. So you can, this is acute rejection is the one which can be suppressed with the help of immunosuppressive therapies. And these acute antibody mediated rejection is more difficult to treat effectively and may require plasmapheresis, acute antibody mediated rejection. So you can reverse most of the episodes of acute cellular rejection, but antibody mediated rejection is very difficult to treat. A very important point here. Chronic rejection. Chronic rejection happens after the first 6 months. Very important. And all types of transplants are susceptible to chronic rejection, and it's a major cause of allograft rejection. The most common cause of allograft rejection is chronic rejection. Interestingly, the liver is more resistant than other organs for destructive effects of chronic rejection. I told you that liver is resistant to hyperacute as well as the chronic rejections. The pathophysiology of chronic rejection is not very well understood, while the allo antibodies are thought to be a major cause, and cellular effector mechanism may also contribute. So the risk factor for chronic rejection of a kidney transplant, this is for kidney transplant only, the previous episode of acute rejection, and most importantly, the previous episode of acute rejection is the most important predictor of chronic rejection, which is given in the subsequent part of the chapter. Second point, which is the risk factor of chronic rejection of kidney transplant, is poor HLA match, long cold ischemia time, cytomegalovirus infection, raised blood lipids, inadequate immunosuppression, including the poor compliance. The single most important factor, very important point, is that the single most important factor, risk factor for chronic rejection after kidney transplant is acute rejection. And with vascular inflammation and with recurrent episodes of acute rejection. A non-immune factors often contribute significantly to the long-term failure of kidney transplant, which are chronic allograft nephropathy. We use the word chronic allograft nephropathy for the non-immune factors. The histological picture of a chronic rejection after the organ transplantation is determined by the vascular changes, with the development of myointimal proliferation. Very important, myointimal proliferation in arteries, which result in ischemia and fibrosis. Myointimal proliferation in arteries resulting in ischemia and fibrosis. If you look in this figure 82.6, this is the acute antibody mediated renal allograft rejection, and there is widespread staining for the complement C4D. Acute antibody mediated renal allograft rejection, staining for complement C4D within the peritubular capillaries. If you look in the severe acute renal allograft rejection with a heavy mononuclear cell infiltrate, these are the acute renal allograft rejections, heavy mononuclear cell infiltrates. Chronic renal allograft rejections, very important, myointimal proliferation and luminal narrowing resulting in ischemic fibrosis. This is the myointimal. These all are the myointimal proliferation. This is the myointimal proliferation, and this is thrombus. The most important MCQ point is coming here, that what are the vasculopathies, what are the organ-specific features of chronic graft rejection? Kidney showing glomerular sclerosis and tubular atrophy. Pancreas showing acinar cell and islet cell destruction, acinar cell loss and islet cell destruction. The heart is showing accelerated coronary artery disease. The liver is showing vanishing bile duct syndrome, and the lungs are showing obliterative bronchiolitis. By far the most important point, kidney showing glomerulosclerosis and tubular atrophy. Pancreas showing acinar loss and islet destruction. Heart showing accelerated coronary artery disease. Liver showing vanishing bile duct syndrome. Lungs showing obliterative bronchiolitis. Next point is graft-versus-host disease. Although the main immunological problem after the transplant is graft rejection, the reciprocal problem of graft-versus-host disease is occasionally seen after certain types of organ transplantation. Some donor organs, particularly liver and small bowel, they contain large number of lymphocytes, and these large number of lymphocytes may react against HLA expressed by the recipient tissue. These are the HLAs expressed by the recipient tissue. Till now, we saw the HLAs by the donor organs. Now we are showing HLAs by the recipient tissues. They lead to the graft-versus-host. This is the difference between the rejections and graft-versus-host disease. The graft-versus-host disease frequently involves the skin. This skin. Causing a characteristic rash on the palms and soles. It may also involve the liver after small bowel transplantation and the GI tract after the liver transplantation. These points are very important. And it's a fatal condition. GVHD is a fatal complication. Now let's look into the HLA matching. HLA chromosome is chromosome 6. Class 1 antigens A, B, C. Class 2 antigens DRDPTQ. And expression of MHC is a codominant phenomenon that genes on both the maternally derived and the paternally derived chromosome. It's a basically haplo. Both the alleles, they come from both the parents, and consequently an individual may express between 6 to 12 HLA types, but these 6 types are more important, which we saw right now. Second point important here is that in addition to the HLA subtype is inherited from both parents and usually inherited as a complete haplotype. We saw that. In addition to reducing the risk of graft loss from rejection, a well-matched kidney allograft that subsequently fails is less likely to cause sensitization. Even though we match all the HLAs and ABOs, there are still chances that the graft will be failed. But if your HLAs are having good matching, they may lead to less chances of sensitization. The subsequent failure will be less, because if you are needed for a further procedures or further transplants, those patients who were having good match during this failed graft will be having less sensitization to the HLAs. So it will be easier for them to get a regraft done. It is particularly important in children and young adults to avoid where possible grafts that are mismatched for common HLAs, because if retransplant is required subsequently, it may be difficult to find an organ donor who does not express the antigens to which the recipient has become sensitized. If any mismatch has been done, now the recipient is sensitized for that. So it will be very difficult for you to find another graft which is having very good matching. And among all the HLAs, very important point, the HLA A, B, and DR are the most important. And in the sequence of this, DR is most important, second is B, and then A. But doctors are most important. Recipients who receive well-matched renal allografts may require less intensive immunosuppressions, and they trouble less by rejection episodes. Now we'll look into the mismatch numbers or matching numbers. There is a number method given to the various HLA matching phenomena. If we call as a 000 mismatch, it means it is a full house and a complete match. All three, HLA A, B, and DR, they both are having, each and every HLA is having two alleles, and both the alleles, if they match, we call it complete match or 000 mismatch. If even a single alleles is having a mismatch, you will call it as 1. If both the alleles are not matching, it is 2. So the meaning of 0, 1, 2 is actually when HLA A loci is having one mismatch, HLA B is having mismatch for both. Sorry, it is A, B, and DR. HLA A, B in this sequence. HLA A is having complete mismatch, a complete match. HLA B is having one mismatch, and HLA DR is having both the alleles mismatch. My bad. Then moving ahead, the allocation of organs for the transplantation must also take into account the relative size of the donor and recipient. And this is not an issue with renal transplantation, as the adult kidneys can be readily used for the children and vice versa. But also in heart, lung, liver, and small bowel transplantation, you have to consider the size compatibility. In the case of liver transplants, HLA matching does not confer an advantage, although it is beneficial for cardiac transplantation, but it is not practical. So HLAs are usually not giving you added advantage in liver, and also though it is beneficial for cardiac, not practical, because there is a relative small size of recipient pool and the short permissible cold in heart transplantations. If you look into these two figures, HLA is on chromosome number 6. The various strands with HLA class 1 and HLA class 2 antigens. And this is a Mendelian inheritance of HLA. Now, tissue laboratory or tissue typing laboratory. It is used to determine the HLA types, the tissue types of all potential organ transplant recipients and organ donors. And this is achieved by applying polymerization PCR based DNA typing techniques to simplify the peripheral blood. Peripheral blood is taken, PCR is done, and DNA typing is used. The second, they have actually three functions. First is this. Second is they perform a cross-match test to exclude the presence of clinically significant circulating antibodies in the recipient, and antibodies against to the HLAs expressed by a potential organ donor that would result in rapid or hyperacute graft rejection. We saw in the hyperacute graft rejection that the antibodies to the HLAs which are expressed by the organ donors, HLAs of organ donors, and antibodies in the recipient. So you have to exclude those factors. And these are the functions of tissue typing laboratory. Then this also involves the incubating recipient sera. How will you do this second part? It is by incubating the recipient sera with donor lymphocytes prepared from either blood or lymphoid tissue. Third is that tissue typing laboratory determines the HLA specificity of circulating anti-HLA antibodies in recipients before and after organ transplantation to guide the organ allocation and immunosuppressive therapy. Next important point is this table of 82.3. table 82.3 is showing us various use of calcineurin inhibitors and immunosuppressive agents and how they function. The corticosteroids, they have a widespread anti-inflammatory effect. Azathioprine, they have anti-lymphocyte proliferation action. Mycophenolate mofetil is having lymphocyte proliferation, anti-lymphocyte proliferation action. Then calcineurin inhibitors block the IL-2. mTOR inhibitors also block the IL-2, but the difference is that calcineurin inhibitors, they block the IL-2 gene transcription, while the mTOR inhibitors, they block the IL-2 receptor transduction. Transcription. Calcineurin transcription. mTOR inhibitors, duction. Anti-CD25 monoclonal antibodies, they target the activated T cells. Anti-CD52 monoclonal antibodies, they cause the depletion of lymphocytes. And anti-CD20 antibodies, which are the rituximab, depletion of B lymphocytes. CTLA4 and immunoglobulin, which is causing the blockage of T cells depletion. These are the site of action of immunosuppressive agents on T cell, ATG, which is anti-thymocyte globulin, and the MPA, which is mycophenolate acid derivative, and mTOR. How they act? The ATG and alemtuzumab, they, along with the CTLA4 immunoglobulin, they block the first step, which is the early activation of resting T cells. The late activation of resting T cells is blocked by calcineurin inhibitors. They have an antigen. The late activated T cells, they have CD25 antigens, and which is blocked by the anti-CD25. And in the last, the proliferation is blocked by mTOR inhibitors. The proliferation after the late activation is blocked by mTOR inhibitors. And what the anti-proliferatives do, which is the monoclonal mycophenolate mofetils and azathioprine, they will block the further proliferation of the T lymphocytes. If you look into this table of 82.4, it is showing us the various side effects of anti-lymphoproliferative drugs, the immunosuppressive agents. The corticosteroid has a vast buffet of side effects: hypertension, dyslipidemia, diabetes, Cushing-Old appearances, osteoporosis, AVNs, all side effects of corticosteroids. The most important is CTLA4, which is causing increased risk of post-traumatic lymphoblastic disorders, lymphoproliferative disorders, post-transplant lymphoproliferative diseases.